All right, guys, welcome back. We're going to go into chapter 14. This chapter is one of the funner ones that I enjoy talking about and teaching about. Really, I think anybody in EMS gets a little bit excited about the bleeding, shock, and soft tissue injuries. It is a little bit longer chapter, and because of that, there are several of these national education standards that we need to go over before we get into it. The first one is our pathophysiology. Use simple knowledge of shock and respiratory compromise to respond to life threats. Shock and resuscitation. Use assessment information to recognize shock, respiratory failure or arrest, and cardiac arrest based on assessment findings, and manages emergency while awaiting additional emergency response. Trauma. Use simple knowledge to recognize and manage life threats based on assessment findings for an acutely injured patient while awaiting additional emergency medical response. Bleeding. Recognize and management of bleeding. Head, face, neck, and spine trauma. Recognize and management of life threats. Chest trauma. Recognize recognition and management of blunt versus penetrating mechanism, are open chest wounds, and impaled objects. Abdominal and genitourinary trauma, recognition and management of blunt versus penetrating mechanisms, eviscerations, and impaled objects. Soft tissue trauma, recognition and management of wounds, burns, including electrical, chemical, and thermal burns, and chemicals in the eye and on the skin. Multi-system trauma, recognition and management of a multi-system trauma. Our medicine, recognize and manage life threats based on assessment findings of a patient with a medical emergency while awaiting additional response. Immunology, recognition and management of shock and difficulty breathing related to anaphylactic reactions. Diseases of eyes, ears, nose, and throat. Recognition of management of a nosebleed. Introduction to this chapter. So our soft tissue injuries and bleeding. Damage to internal soft tissue injuries and organs can cause life-threatening conditions. So our internal bleeding results in shock, which is inadequate tissue perfusion to any of the organs. It's important that as emergency medical responders, we are able to recognize and care for patients who are in recognize and care for patients that are suffering from shock related to their soft tissue injuries. Most of our trauma patients actually end up dying from shock related to their soft tissue injuries and the loss of blood or internal bleeding than any other condition. Our patient assessment for our bleeding, shock, and soft tissue injuries is going to be the exact same as we have with all of our other conditions and everything else we do. We're going to start with our scene size up. This is that 5,000 foot view where we initially arrive on scene, we're looking out, we're seeing if there are any possible hazards, anything that we need to be aware of before we get any tunnel vision and go and start looking at the patient, not paying attention to the things around us. Our primary assessment is looking for those life threats, looking at our airway, breathing, circulation, creating a general impression of the patient. Next, we move on to our history taking, getting all of the information leading up to the incident that we can, go into a full body secondary assessment, and then continually reassess. When you begin that primary assessment phase, like I said, we're looking there for life threats, our airway, breathing, and circulation. And so if you start that assessment and you notice that they are losing blood, then we need to stop the rest of the assessment and immediately stop that bleeding. There is another algorithm that we use to help people understand the steps that we take for massive bleeding. This is used in the military and in tactical EMS situations, but we use MARCH instead of our ABCs, our airway, breathing, and circulation. We are doing MARCH, or sometimes it is referred to as our HABCs, and the H stands for hemorrhage. And in MARCH, we have massive hemorrhage, airway, respirations, circulation, and then we look at our hypothermia and warming those patients up. No matter which one of those you want to think about, whether you think about HABCs or MARCH, or if you just want to remember your ABCs and know that if they are bleeding, the most important thing that we need to do is stop that bleeding before we go on to any further assessments. As we perform our reassessment, we're going to look to see if the interventions that we did or the treatments that we did are helping or harming the patient. So we're going to look to see if they are, so we're going to look to see if they have started to So we're going to look to see if their skin is starting to become pale, if they have increasing pulse rate or decreasing blood pressure. These would be signs that we either miss something or that they have internal bleeding that hasn't been addressed. There are standard precautions that we need to take whenever we are dealing with body fluids and potential infection. So that means we're going to be putting on our gloves. If appropriate and we have it available, we may want to wear a surgical mask or eye protection to make sure that there isn't any splashing blood that may get into our mouth or our eyes. And with all of our patients, we just want to make sure that we're protecting ourselves against airborne infections if that is a concern at the time, or if the situation warrants, such as what we just went through with the pandemic. We've covered bits and pieces of this diagram in other chapters. This is kind of looking at it once again as a whole. We're looking at the heart and the lungs and the way that the blood circulates from the heart to the lungs to pick up that oxygen and offload the carbon dioxide, and then return to the heart and circulate through to the body, where at the capillary level, it offloads the oxygen to our cells and picks up the waste products, namely the carbon dioxide. Remember that the heart is a pump and that its function is to make the blood go round and round. We do have 4 separate chambers of the heart. 2 upper chambers are the atrium. We have the left and right atria, and the 2 lower chambers, or the bottom chambers, and the 2 lower chambers of the heart are the right and left ventricles. This is the same diagram that we have seen in other chapters. This is looking at the different parts of the heart. Just a reminder and refresher, talking about the pipes or the arteries and veins that we have that are carrying the blood around to the body. Arteries are the muscular vessels that carry blood away from the heart under high pressure. Capillaries are the network of smaller pipes that actually distribute the oxygen to the cells at the cellular level. And then the veins are the softer, less muscular, and then the veins are the softer, less muscular vessels that carry the blood back to the heart. We've briefly talked about the components of blood in other chapters. This is just a refresher. The liquid part of the blood is the plasma. We have the red blood cells that carry the oxygen and the carbon dioxide. And sometimes we have carbon monoxide that will actually displace the oxygen off of those cells. We have our white blood cells that help us fight our viruses and infections, and then the platelets that are used for clotting. We've talked about checking for a pulse and what a pulse is. Remember, it is a pressure wave that's generated as the heart beats and that blood flows out of the heart and through the arteries. We're able to feel that flow of blood through the arteries as we compress the artery against a solid part, mostly bone, and we're able to feel each one of those heartbeats, either from our carotid, our radial, our femoral, or our brachial. So remember, we've said before, shock is defined as a failure of the circulatory system, which has led to inadequate tissue perfusion to the body. So whatever part of that circulatory system, whether it be the pump, the pipes, or the fluid, has failed and the blood is no longer circulating, allowing the oxygen to be delivered to the cells. So we end up with this inadequate tissue perfusion. Cardiogenic shock is one of those where the heart itself, the pump, is the problem, and it no longer is able to squeeze to send the blood out through the body. This pump failure can occur from a heart attack or any other thing that stops the heart from being able to pump. Sometimes we will see this in medical conditions such as congestive heart failure. If the shock is caused by a pipe failure or the vessels are the problem, often what has happened is those vessels have expanded so much that the fluid is able to move freely in and out of the vessel. So this causes blood to pool in the capillaries. The rest of the body becomes deprived of the needed nutrients, and we will see a fall in our blood pressure because if you remember, our blood pressure is looking at the squeeze of the heart and the pressure on the arteries as that blood goes around. If those pipes have expanded, then there's going to be a lower pressure inside of those pipes. This type of shock, we will normally see our patients faint. And oftentimes this can be as an emotional response or a physiologic response from an overactive nervous system. The nervous system allows those capillaries to suddenly expand, and then our patients will faint. They're unconscious for a short amount of time. If they're laid flat, we talk about the shock position, raising their feet, allowing that blood to kind of flow back to the brain, then they start to wake back up. We also will see this type of pipe failure and expansion of the pipes in anaphylactic shock. And this is caused by an extreme allergic reaction to any number of foreign substances. Our patients are going to appear flushed. They may have difficulty breathing, and then the blood pressure will drop rapidly. A couple of the other things that we can see that cause a pipe failure, we have septic shock. This is caused when there is a overwhelming infection that has gone systemically throughout the body. The vessels will then begin to expand. Like we said, they become leaky, and the fluid leaves the vessels and goes into the external parts of our body, into our tissues, but not actually in the pipes where we need it. And this is a life-threatening emergency. It often occurs in older adults, but we see it in all different ages. It's important that they are treated rapidly, just like all of our other shocks. And then spinal shock, this is sometimes referred to as neurogenic shock. This is when there is some type of spinal cord injury from a traumatic event, and that sudden injury to the spinal cord has stopped impulses going from the brain to the vascular system and has allowed that expansion of the blood vessels, allowing the blood to leak out. Any of these pipe failure problems, whether it's anaphylaxis or sepsis or neurogenic shock, all of these, as we have that drop in blood pressure, as the fluid leaks out of the pipes, then we end up with this inadequate tissue perfusion to the brain and heart and lungs and other vital organs. And that is when we see them progress in their shock, leading eventually to death. So we've talked about the pump being the problem. We've talked about the pipes being the problem, but we can also run into a problem of fluid loss where there's not enough fluid to go round and round in the system. This is normally caused by excessive bleeding. This could be from a massive wound where we have extreme blood loss. So remember, like I said, if we see that blood loss, we need to stop it early so that we don't go into this type of shock where we have hypovolemic shock. the heart continues to pump faster and faster and faster, trying to maintain that pressure and trying to maintain circulation to the body. And eventually, it just gives up as there's not enough fluid to go around anymore, ultimately resulting in a cardiac arrest. External bleeding is not difficult to detect. Anytime you see bright red bleeding or excessive bleeding, it's easy to look and say, yes, I know that this patient is bleeding and we can do something about that. Internal bleeding becomes a little more difficult for us to recognize. So some of the signs that we're going to look for is we're going to look for bruising or swelling in the soft tissue. We may start to see, as the bleeding increases, that area may begin to become rigid and they may have pain or it may feel warm to the touch. Whether we are seeing any external bleeding or whether we suspect internal bleeding, all bleeding that remains unchecked, that isn't treated immediately, will result in shock, that pump failure, and eventually death. The average adult has about 5.5 to 6 liters of blood circulating through. In females, we generally see about 5.5. With males, we'll see 6. So right here, I have a representation of 5.5 liters. And at any point that we have lost 1 liter, that can lead to shock in our patients. So that's not a whole lot when you think about the overall circulating blood volume in our patients, to think that 2 of these bottles worth of blood could lead them to shock, and if not treated, eventually to death. Some signs and symptoms of shock. As it continues to progress, the body is going to alter its function in order to try and maintain that normal blood supply, in order to remain functional. It's going to start shutting some things down to shift the blood where it needs to be. As that happens, we might start to see signs of confusion or agitation. They may become very anxious. We're going to notice their skin is going to become cold and clammy. This is because as that blood is moved to the internal organs, it stops sending blood to the skin or out to our peripheries. So it's not going to have that ability to stay warm anymore. You're going to see rapid, shallow breathing. You're going to see these rapid, weak pulses caused by the heart just trying to keep up and trying to keep that circulation. But we may have a weak pulse because the pipes have expanded to the point where there's no fluid going through, or it may be that there isn't enough fluid circulating through anymore. So those pulses will begin to feel weak. We talked a little bit about checking our capillary refill time in the patient assessment chapter, but remember, our capillary refill time is we are going to our nail beds or some other part of our skin that we can easily assess. We compress that and make sure that the blood is moved out. And then as we release, we're seeing how long it takes for the color to come back into that extremity. The other thing that happens as our blood starts to shift, the other thing that happens as our body starts to shift where the blood is going is at this point, our digestive system is no longer a necessity to maintain life. So your body will stop sending blood to your stomach and your intestines. This will cause you to become nauseous and eventually start vomiting. And then we may have this continual thirst as we have the need to increase our volume. Our body will want fluids so that it can increase that volume. Our general treatments for shock, first thing we want to do is we want to make sure we're positioning them in a way that is effective for what they're... The first thing we want to do is make sure that they are positioned correctly. And how we're going to position them really depends on what's going on with that patient. If we're able to, and if there's no head or neck injury, we can place them flat on their back on a horizontal surface with elevating their legs. We can also use towels or blankets to place under the patients to make them a little more comfortable. Sometimes, though, this isn't going to be the best thing for our patients. If the patient is having chest pain or difficulty breathing, they may not want to be laying flat, and they may want to be in a different position for their comfort. So at that time, you would have them sitting up and either fully upright or semi-upright, and allowing them to maintain a position of comfort for their difficulty breathing or chest pain. As with all of our patients, we want to make sure we're maintaining their airway, breathing, and circulation. If needed on these patients, we want to perform our rescue breathing or begin CPR if they have gone into cardiac arrest. We want to try and look for and treat any signs of shock if possible. All of these patients are going to need to be treated at a hospital, but you might be able to begin treatment in the field. Once again, the most common that we're going to end up treating is our external bleeding by putting on a tourniquet or some other method of direct pressure on that bleed. With these patients, we don't want to allow them to eat or drink anything. As we said, the blood in our body is going to start to be shunted away or moved into different locations. Our digestive tract is not one of the locations that's going to be receiving any blood. So allowing them to eat or drink is actually going to increase the chances that they will vomit. And also, a lot of these patients that are in shock may need surgery to fix whatever is causing their shock. And our anesthesiologists don't like when their patients have any food in their stomach. It increases, once again, that chance of vomiting and aspiration. So making sure that we don't allow them to eat or drink anything once we come on scene is very important. These patients might, like we said though, they are going to be thirsty. So it's a little counterintuitive where they're thirsty, but we're not going to allow them to eat or drink anything. If you work in an area where your ambulance response time is going to be more than 20 minutes, you may allow them to put a little bit of water on a piece of gauze or a clean cloth and allow them to kind of suck on that. That will help them moisten their mouth without giving them excessive fluid and causing problems that might lead them to vomit. With these patients, remember, shock is inadequate tissue perfusion. So this is one of those times where if we have it available, we do want to be giving them oxygen. That just increases the amount or the availability of oxygen that is then circulated through whatever blood is in the pipes so that they can increase the perfusion to the cells. Once your advanced providers, your advanced EMTs, or your paramedics arrive on scene, they will start an IV and administer fluids through that. At that point, we're just going to assist them in arranging for transport and making sure that they can get to the hospital and have their shock treated effectively. Treatment for our pump failure shocks. This is a very serious condition, and these need to be immediately transported to the hospital for their best chance of survival. If it is a pump problem, often these patients are going to progress into a cardiac arrest. So just being aware of that and ready to perform CPR when needed is very important. talking about some of the treatments for our pump failures. Treatment for anaphylaxis. This one we need to transport as soon as possible. If it is a known allergy and the patient knows that they have an anaphylactic reaction, they may have an EpiPen auto-injector. If your local protocols and medical direction has allowed you to do this and you have been trained, then you can assist the patient in using their epinephrine auto-injector. With these, you're going to place it against the outer thigh. These epinephrine auto-injector trainers are very helpful in practicing the steps so that you would be able to help administer somebody else's epi if needed. What you're going to do with these is you're going to support the patient's thigh. You're going to remove the blue cap. You're going to place this firmly against the patient's thigh and push in. And you're going to hold it for several seconds, about 3 to 5 seconds, and then you'll be able to pull away. I don't recommend doing it into your hand. I was just trying to show you guys, and this is a trainer. Our treatment for our neurogenic shocks, this is going to be keeping the patient, and this is going to be keeping the patient's spine in a neutral position, supporting their airway, breathing, and circulations, and then treating for any of the symptoms that we see associated with their shock. So if we need to keep them warm, we will treat any of the symptoms of shock that we see and arrange for prompt transport to a medical facility. Treatment for our septic shock patients, once again, same thing. We're going to treat the ABCs, treat any of the symptoms that we see, and arrange for transport. Treatment for shock caused by fluid loss. The most important thing is to stop the bleed if able. If it is caused by an internal bleed, such as a stomach ulcer or a tumor or some other internal trauma that has happened, it becomes more difficult for us to treat and recognize. But we might see some signs and symptoms such as coughing or vomiting up blood, abdominal tenderness and rigidity. We may see vaginal bleeding in women, or we may see the classic signs of shock with that pale, cool, clammy skin, our rapid pulse, our rapid breathing. Looking at controlling our external blood loss, there are different types of blood loss that we need to be able to recognize. The first one there you see on the finger, this is going to be capillary bleeding. I'm sure everybody's familiar with this, just a little cut on your finger. You'll have a little bit of blood, it just oozes out. You'll have a little bit of blood, maybe it oozes out, but it's really not very extensive. Then we can have venous bleeding. Venous bleeding is generally a steady flow, but not necessarily a pulsating flow. You'll just see it continually coming out of the wound. And then our arterial bleeding, we would start to see that pulsating flow, that with every heartbeat, we see a little bit more blood come out. If it's one of our major arteries that has been affected, that blood can squirt out quite a bit. It's really difficult sometimes, though, to tell the difference between venous bleeding and arterial bleeding, especially when it's some of the medium-sized vessels that have been affected. With our capillary bleeding, the way that we're going to treat this is just applying direct pressure to the site. We don't need anything more for that. With our venous bleeding, this steady flow, it's important that we apply direct pressure. That direct pressure needs to be applied for an extended amount of time, upwards of 5 minutes or more. And it becomes difficult then for us to do anything else as we are holding that pressure. So at that time, we may start to use other things such as pressure bandages to wrap and control that pressure. Next is the arterial bleeding. This is going to require surgery to fix. Direct pressure might help with these, but really the most effective thing for our arterial bleeding is going to be a tourniquet. Direct pressure for our capillary and venous bleeding, all we're going to do is take a dry, sterile dressing. We're going to put it over the wound with a gloved hand, create that pressure, and then dress the wound with some type of compressed gauze or a compressed bandage. Some of those bandages that you might see, we have emergency trauma dressings. This is a bandage that is essentially its own compression wrap that has a piece of gauze already on it. So you would take this, as it says, other side towards wound, so you know that that is our clean side. You would place that onto your wound and begin to wrap. And that will help us create pressure directly onto the wound. If you don't have emergency trauma dressings available, then you can use standard gauze and cover that wound, and then use a compression wrap such as an ACE wrap. It's important that once you have placed any of these bandages, that you just leave it alone until further. It's important that once you have placed one of these wraps or created that direct pressure, that you don't remove the bandage after you've applied it. There are some exceptions to that that we will talk about. Another thing that we can do for controlling external bleeding is going to be to elevate the wound. Once you've created that direct pressure, you can elevate it above the heart. That reduces the amount of pressure going up and will hopefully slow the blood flow to that extremity. Like I said before, the really the most important thing for controlling severe external blood loss is going to be a tourniquet. And for a long time, tourniquets were taboo and they went out of favor. Everybody was worried that if you used a tourniquet, they were going to lose their limb. And so this was a last resort instead of a first-line treatment. The military has done extensive studies on this. The tactical EMS environment has done extensive studies on it. And if done properly, tourniquets do not cause you to lose limbs. You may lose a limb due to the injury anyways, but the tourniquet itself is probably not what's causing that if used correctly. And then the other thing is, with tourniquet placement, they have found that tourniquets can be on for 2 hours without any signs of tissue damage or nerve damage. In the military, they're even allowing first responders and the medics to remove tourniquets and convert them to pressure dressings using our gauze and pressure bandages up to 2 hours after the injury. So don't be afraid of using tourniquets. Like I said, I know there's a lot of information out there about how they're dangerous. They're not. You can use them. I encourage you to use them. And in most situations, you're going to have EMS arrive, you're going to have advanced providers show up, and they are going to get to a hospital well within that 2 hours of initial injury. So we're going to just quickly talk about controlling bleeding using tourniquets. You may see a number of different tourniquets on the market. It's very important that if you are going to purchase a tourniquet, you buy them from a reputable dealer. You make sure that you are using what's called COTC. It's the Committee for Tactical Combat Casualty Care. They have an approval for certain tourniquets, and make sure that you are getting good quality tourniquets. The CAT tourniquet is probably the most common tourniquet that you're going to see around. I think it was probably the first really commercial tourniquet to come out for the military, but because of that, it is the most copied tourniquet that you will see. And there are a lot of counterfeit CAT tourniquets out there. I've played with a lot of them. I've tried to test them out. They have huge failure rates. So don't trust your life or somebody else's life to a knockoff tourniquet. Make sure you're getting good quality equipment. So the two that I have here, I have the CAT tourniquet. Like I said, this is probably the most common that you're going to see. And then I have the SAM medical tourniquet. It's quickly becoming one of my favorites, and we'll talk about why. But first, when applying a tourniquet, we want to make sure that we go about 2 to 3 inches above the wound. If you can't tell where the wound is because of clothing or something else, try and clear that clothing away. Make sure that we're just going 2 to 3 inches above. You can place tourniquets on the lower arm. There has been, once again, some false information out there about how you can't put tourniquets over 2 bone compartment areas like the forearm or the lower leg, but you absolutely can. So just make sure that you have the tourniquet 2 to 3 inches above the wound. The most common failure point for tourniquet application is not getting it tight enough to begin with. And so you want to make sure that as you're putting this tourniquet on, that you get as much slack out of there as you possibly can. Make sure it's tight. It's going to hurt. Tourniquets aren't comfortable if put on properly. So you want to tighten it down as much as you can before you ever start turning the windlass. And this will give us more compression once we start turning this windlass rod here that helps create that circumferential pressure. So once it's tightened down, you just start to turn the windlass. In general, it takes about 2 turns for it to be effective and actually cut off all the circulation below that injury. Once you have it tightened down, you want to make sure and secure that extra tail so that it doesn't get pulled loose. All of our tourniquets will have some type of securing strap that will cover that, and it has a spot for us to write the time that we have put the tourniquet on, so that as they arrive at medical treatment facilities, they now know how long it's been on, because that will dictate the treatment that they give and how they release it. So once you have it on, you want to make sure that there is no pulse felt below that application. Some people will teach that you turn it until the bleeding stops. This can be problematic in our patients where it is a major vein that has been injured, and we may stop the bleeding from that vein, but we haven't necessarily stopped the blood from the arteries that go past that. And remember, the arteries are more muscular and have higher pressure. So if we cut off the veins, but we have not cut off the arteries, then we'll end up with blood flowing in that can't flow out. And that is when we start to have problems caused by our tourniquet application. So it's really important that we make sure that these tourniquets are applied as tight as we can and that there is absolutely no pulse felt below the application. So, as I said, one of the major failure points, and probably the most common failure point in applying a tourniquet, is not getting it tight enough before we start to turn the windlass. And so Sam Medical, who makes other medical devices, they have come up with a really cool way to make sure that we get it tight enough. And what they have done is they have a buckle here that will snap in place once we have pulled tension. So as we pull, there is an audible click. And the cool thing about the Sam tourniquet is once you have that audible click, there are teeth that come out and go into and grab in these holes on the tourniquet. And so I can let go of the tourniquet at that point and it's not going to come loose. Whereas if I let go of the cat prior to putting down the Velcro, it would come loose. So 2 cool little features that I really like about the Sam is that tensioning device that makes sure we have pulled it tight enough just so there's no question about whether or not you've turned it all the way. And then it has a metal windlass rod. So as you turn this, you're able to get a lot of pressure behind it. You would do the same thing with these. You want to make sure that you run that tail through the opening and then secure it and write the time on it. Most of the approved tourniquets are going to function exactly like this. There's very, very few exceptions to how they operate. One thing that I would caution as well when you're looking at tourniquets and making sure that you're getting approved tourniquets, there are a number of tourniquets out there that are rubber bands or giant compression band things. Those are fantastic for our pressure dressings and different things, but they are not approved and tested tourniquets for controlling that massive external hemorrhage. Another very effective way for controlling external bleeding, if it doesn't require a tourniquet or if it's in a location where we can't get a tourniquet. This is going to be major bleeding up in the neck, or if we have major bleeding in the armpits or in the groin where we're unable to get a tourniquet, we can use hemostatic agents. These were initially made for the military. They provide rapid clotting if used properly. You're going to see it comes in a gauze. This is generally impregnated with whatever the hemostatic agent is. There used to be powders around, and they still may be floating around there a little bit, but most of what we want to be using are the gauze that have some type of hemostatic agent on it. These are really good because you can use them to pack a wound. And so what you're going to want to do with these is you want to clean out the wound as best as you can. You want to find the source of the bleed inside that wound, and then you're actually going to shove the gauze all the way down in the wound so that it's at the source of that bleed. And you continue to pack the gauze in on top of itself, keeping pressure directly on that wound. You will fill the entire cavity as you're pushing that gauze in, making sure there are no other nooks or crannies that you could get the gauze into, continually keeping that pressure on top of it. And then once the entire wound is filled as much as you possibly can, you take the excess of the gauze, you stick it on top of the wound, and you hold pressure. Now, it's important that with our hemostatic agents that we hold pressure for an entire 3 minutes prior to any wrapping or anything else. Each of the hemostatic agents work a little bit differently. The combat gauze, which is probably the most common that you're going to see, works by actually going into the bloodstream and working with the clotting cascade in the body to form a clot. The other that you might see, the others that you might see will interact with the blood and create a gel-like substance as it comes in contact with the blood and creates a clot that way. For that reason, it's important that if your combat gauze becomes completely soaked in blood after you have placed it inside the wound, after you've packed it, after you've placed that pressure dressing, if it has become completely soaked in blood, then it is no longer effective and it's no longer stopping the bleed. So at that point, you would have to remove it and redress it and repack it. So that is the exception that I talked about earlier when I said that once you've placed direct pressure, you don't remove it. So the only exception to that would be if using our combat gauze and it has become completely soaked with blood, you would remove it and put more combat gauze, if available, directly on the wound. If you don't have hemostatic agents, you can always use regular gauze and do the exact same thing and pack those wounds. As we've talked about before, we want to make sure with every patient that we are coming in contact with any of their bodily fluids, blood included, that we are using standard precautions. Make sure we're wearing our gloves. If you do get any blood on your hands, wash it off as soon as possible. If you can't wash your hands with soap and water immediately, if you have any waterless hand cleaner, then you can use that as well, as it will kill the germs. So now we're going to go into talking about different types of wounds. We've talked about controlling bleeding, but now we'll talk about different kinds. So a wound is any injury caused by a physical means which leads to damage of a body part. They're normally classified by either an open wound or a closed wound. A closed wound simply means that the skin remains intact. This is going to be seen in our soft tissue injuries that lead to bruising. It's caused by small blood vessels being broken below the skin. The area will start to become discolored and start to swell. Bruising Bruising isn't always simply soft tissue localized injury, though. Bruising and swelling can sometimes be a sign of an underlying fracture or further damage. An open wound is any time the skin is broken. This can be as simple as an abrasion or a scrape that occurs as the skin is rubbed across a rough surface. So on any of our rug burns or anything like that. We can also have punctures. This occurs when any sharp object penetrates the skin. We might have deeper injury than we initially suspect with punctures, as it can go deep enough to affect any of the internal organs or other structures inside the body. Puncture wounds don't always bleed freely, or we don't have this continual pool of blood. It all depends on if a blood vessel was injured during that puncture. Gunshot wounds is a special type of puncture that we have to pay attention to, specifically because with gunshot wounds, there is an entrance and an exit usually, but it creates a cavitation within the body. So you may see a small entrance wound and a larger exit type wound, but within there, it will expand and create a larger wound inside as the bullet travels through the tissue. Here is an example of a puncture wound caused by a nail. Another open wound, and the most common, is our lacerations. We normally call these cuts. Our minor lacerations require very little care. These are ones that are affecting the capillary level. Once again, we're just putting direct pressure on them, maybe some type of gauze or other bandage, wrapping them and keeping them clean. Our larger lacerations are life-threatening, and those are the ones where we need to be thinking about using our tourniquets. Here is an example of a laceration. We also have avulsions and amputations. An avulsion is any time that an avulsion is any tearing of the body tissue. An avulsion is tearing away of body tissue. If the entire body part is torn away, then we call that a traumatic amputation. Amputated parts, if we are able to, we should locate them, place them in a clean plastic bag, keep them cool. It used to be taught to keep them on ice. This is not recommended, as it will actually freeze the tissue and makes it difficult, if not impossible, for it to be reattached. And it's not always possible for them to reattach anyways. It is also important to understand with any traumatic amputation underlying. It is also important to understand that with our traumatic amputations, the blood vessels around that traumatic amputation will actually constrict down and kind of suck up into the body. And that is a protective mechanism so that you don't bleed out. But as time goes on, as the adrenaline wears off, then those blood vessels will begin to relax and the patient will start to bleed. So it's very important that any traumatic amputation, especially of an extremity, we want to go ahead and put a tourniquet on them, even if we don't see bleeding initially, because as they relax, those blood vessels are going to relax as well, and they will begin to bleed later on. So all traumatic amputations of the extremity need a tourniquet above that amputation. Here is an example of an avulsion. It's raised flap of tissue. Often you can see significant bleeding from these. Principles of wound treatment. We've already talked about all of these. Our minor injuries, our bruising require no treatment. All of the others we can begin our treatments. If it is a soft tissue injury and there is significant bruising, we may apply ice and some compression to it, elevating the injury. We can splint. We can begin splinting some of those injuries, which we will talk about in our next chapter. And the most important, and I can't state this enough, the most important is to stop bleeding as quickly as possible. As we dress our wounds after we've controlled that bleeding, we want to prevent any further contamination if we can, so cover it with a clean, sterile dressing and immobilize it as much as possible to prevent any movement that may further the damage. We'll talk about dressings a little bit and some of the different dressings that are available. A dressing is any object that we're placing over, is any dressing that we are placing directly on a wound to control or prevent bleeding. The most common dressings that we're going to see We're going to have our 4x4 gauze. We may have some of the heavier abdominal pads, our 5x9 trauma pads, and we can even see larger 10x30-inch trauma dressings as well. Here are some of those different sizes. If you have placed a dressing on a wound and it continues after you have applied compression, you can add additional gauze over the original dressing, with the caveat, like I said, if you're using combat gauze, you need to replace that initial dressing. And also there becomes a point where as you're adding those dressings on top, if they are continuing to bleed through, it may be more beneficial to remove them, find the source of the bleed, and apply direct pressure to that bleed. As we just keep adding more and more bandaging, it becomes more difficult to apply that direct pressure. We've talked about different types of gauze. Here I have compressed gauze, but they also have rolled gauze. We can use triangle bandages or our compression bandages. The principles that we're trying to follow when we are dressing these wounds is we want to make sure that the wound is completely covered. We want to go beyond all sides of that wound, and we want to wrap just tightly enough that we control the bleeding, but not tight enough that it cuts off the circulation. If we've done that, then it becomes a tourniquet. And if you remember when I talked about tourniquets, we want to stop all blood flow, but if we tighten down a compressed gauze or something like that, it's not going to have enough pressure to stop the arterial flow. So we may stop venous flow, but not arterial, and then we'll end up with blood pooling in that extremity, causing what's called compartment syndrome, and that is dangerous for our patients and their limbs. Once we have made sure that our wrapping is not too tight, that it's not cutting off circulation, that they still have good blood flow to their extremities, then we want to secure the bandage so that it doesn't slip and come loose. Face and head wounds are kind of an interesting topic because even very small lacerations to the face or head will actually bleed quite a bit. Despite the fact that they bleed quite a bit, they are very easily controlled with direct manual pressure. So with these, we want to take any of our gauze, our 4x4s, and put them directly on. Like I said, this is one of those times where I've seen far too many 4x4 dressings placed onto a scalp where what they really need is just a finger directly on that source of the bleed, and that controls it. So direct pressure works very well with these type of wounds because you're able to create the pressure against the skull, and so there's a hard surface no matter where you push to create and help create that pressure. If you do happen to have wounds inside the mouth or inside the cheek, you can take that gauze and insert it into the mouth. You just want to make sure that you're not creating an airway obstruction at that point. Also, with our scalp wounds, it may be associated with further injury, such as a skull fracture or a brain injury. So it's important that as we're creating that pressure, that we don't push too hard that might cause any bone fragments or other injuries to further the damage there. So we just want to create the pressure enough to stop the bleed and then cover the wound. If we do have any head injury or neck injury associated with our scalp wounds, we want to make sure that we're moving the head as little as possible, trying to stabilize that neck, and then monitoring the patient's airway, breathing, and circulation, and protecting their spine. So next, we're going to talk about nosebleeds. Nosebleeds can result from either injury, high blood pressure, or even dry air, depending on the region that you're in and how dry the air actually is. Nosebleeds can start without any apparent cause. And with all of these nosebleeds, the most important thing is, unless the patient is experiencing shock, that we just want them to have unless the patient is experiencing shock and it's an extremely bad nosebleed where unless the patient is experiencing shock from an extremely bad nosebleed that just can't be controlled, we want to have the patient sit down and tilt their head slightly forward. As they tilt their head slightly forward, we're just going to pinch both nostrils together and hold that for about 5 minutes. Sometimes nosebleeds will persist even after that, and for these patients, we want to arrange transport so that we can get them to an emergency room where they can have further treatment to try and stop that bleeding. Another type of injury that we can have is our eye injuries. Anytime that we have a laceration or suspect that there's an injury to the eye, we want to cover that eye with a dry gauze pad. If the patient is comfortable doing so, you can have them lie on their back for transport. This isn't necessary. Sometimes they're going to be more comfortable sitting up. It just depends on if there is something impaled into the eye and we need a better way of controlling that. If it is a small foreign object on the eye, something that you can see and easily flush out, like a metal flake or wood flakes or something, we can also use saline solution to flush that out of the eye prior to any of our bandaging or transport. Like I said, if there is an impaled object and we're trying to figure out a good way to stabilize that for transport, this is the time where it may be best for them to be on their back, or they may be more comfortable being up. Any impaled object, no matter where it is in the body, we never want to remove an impaled object. We just want to pad around it, keep it in place as we transport. The problem with impaled objects into the eye is that both eyes will move together. And so you want to make sure that you're bandaging both eyes, trying to prevent them from looking around and looking at you while something is sticking out of their other eye, because it will move the same as the uncovered eye. So with these, we're just going to use some type of bulky dressing, often a paper cup or a styrofoam cup that we can poke a hole through the end and stick it over top, is a great way to stabilize these and make sure that they stay in place as we transport them to the hospital. Neck wounds, we talked a little bit about when we were talking about packing our wounds, but if you're able to, just put direct pressure on it. If you can control the bleed through direct pressure, then you can dress it. Sometimes it's difficult to get a dressing to stay in place on the wound. They do make these see-through bandages. Tegaderm is kind of the name brand that you might see that would be able to help hold those in place. The one thing we want to avoid doing when we're when we are covering those wounds is we never want to circumferentially wrap around the neck to hold that in place, as it can cut off our airway, make our breathing difficult, but it also can cut off circulation going to the brain. So with these, if we do need to create pressure on one side or the other, you can create pressure by holding it against the neck and then going under your armpit as somewhere to create that pressure on either side. Any major trauma to the neck, we also need to be aware and make sure that we're assessing that there are no associated airway problems or that there isn't any type of spinal injury associated with that neck wound as well. So we want to make sure that we're keeping their airway open, that we're stabilizing their head and neck, and continually reassessing our ABCs. We can have chest and back wounds. Any of our chest wounds, we want to make sure that our patient is in a position of comfort. Oftentimes, these patients may want to be sitting up. If the lung is punctured, it can cause air to escape or even collapse. These patients, in late signs, you may start to see them coughing up bright red blood. Realistically, though, more common every time I've seen one of these patients, they're going to be extremely anxious. They're going to continually be repeating things like, I can't breathe, I'm going to die. That is the most common things that I see in these patients. If there is a puncture to the lung and you suspect that it is causing that lung to collapse, we want to cover that open chest wound with an occlusive dressing, just something that the air can't go through. You can use wrapping from any of your bandaging. Just make sure that you tape down all the sides. You want it to extend 2 inches past the wound. They also make commercial occlusive dressings that you can stick on those patients. They have vents in them. So if you have any of the commercial dressings, you can go ahead and slap one of those on as well. Any of these patients, as we said before when we were talking about shock, these are the type of patients that we do want to make sure we're giving supplemental oxygen to, and is making sure that we are monitoring their oxygen levels using our pulse oximeters. If there is a chest wound, there's always the possibility that not only has it damaged the lungs, but that it has damaged the heart. So we want to seal all of those wounds. We want to continually reassess our airway, breathing, and circulation, treating for any signs of shock that we may see. If we have patients where their breathing becomes more labored after we have sealed the wound, it may be necessary to remove the seal briefly, what we call burping the wound, to allow excess air to escape. That would be if you are using some type of if you are using some type of makeshift cover that doesn't already have a vent built into it. It's also important to remember the diaphragm we talked about before. When we breathe in, our diaphragm flattens out as it creates that air, as it creates that area for the air to move into our lungs. Because of that, our diaphragm can go down almost to the level of our belly button. So you may end up with a wound into the abdomen and not realize that it is actually a wound to the chest, just because that diaphragm had been down and they had been inhaling at the time of the injury. Talking again about impaled objects, I already mentioned any impaled object we want to leave in place. If any impaled object we want to, as I said before, with any impaled object, we want to leave it in place as we transport them to the hospital. If it is a large impaled object that's going to impede your ability to get them into a transport vehicle, it may need to be cut down if you're able to, so that you're able to get them in. Oftentimes, these impaled objects may be tamponading a bleed. They're actually creating the pressure needed to stop the vessel from bleeding. And so as soon as we remove it, then we create further problems with them bleeding. Just like impaled objects in the eye, we want to support it to make sure it's not moving, creating any further damage while we transport, and use some type of clean gauze or sterile dressing on either side of it, just trying to reduce the amount of infection and other contamination that may happen around that entry point. We can also have some of our closed abdominal wounds. These result in direct blows from a blunt object. With these blunt abdominal wounds, with these closed abdominal wounds, we want to look for bruising. We may see tenderness and rigidity due to the blood, which we have already talked about earlier. These patients, we want to place on their back, elevate their legs, treating for shock, and then use blankets to conserve body heat. If these patients are vomiting, pay attention to if they're vomiting blood. If it is bright red blood that they are vomiting, it could indicate that there is bleeding from the esophagus as well, or the stomach. So then we need to monitor and make sure that we don't have any airway problems, continually monitoring our airway and vital signs. And as with all of our patients, we don't want to give them anything by mouth, as it may make that vomiting even worse. Our open abdominal wounds, these are normally caused by slashing from a knife or some other sharp object. It can sometimes cause our intestines to actually come out of our abdominal wall. If this happens and we have exposed intestines, we don't want to try and force them back in. What we want to do is we're going to create a position of comfort for them. We're going to cover the intestines with a sterile dressing that is lightly moistened to make sure that nothing is sticking. That position that we're going to use for these patients, it's a way that we take pressure off of their abdomen. So as we lay them flat and we bring their knees up, it takes some of that pressure off of the abdomen so that it's not creating so that it's not forcing those muscles against the protruding intestines, cutting off circulation to them. In the case that you do have genital wounds, genitals, both male and female, are rich in blood supply, so these injuries can result in severe bleeding. As with any of our other wounds, we're just going to apply direct pressure using a sterile dressing. It's important to note that as emergency medical responders, as people in EMS, it may be embarrassing, but it's also our job to make sure we are examining these areas. So if you suspect injury, you need to make sure and look. The one thing I would say, going back to the direct pressure, is especially with female genitalia, as we're creating that direct pressure, we don't want to pack anything inside of the genitals. So just direct pressure on the wound as close to the site of bleeding as we can. We've already talked about extremity wounds. We need to start out, if we can, with our venous or capillary bleeding by applying the dry sterile dressings, elevating, not forgetting to move to tourniquets early if we suspect major bleeding. Not forgetting that we can always move to tourniquets, and moving to them early is indicated with severe bleeding. Anytime we have an extremity wound, we want to splint the injury prior to transport to make sure that if there is an underlying fracture that we're not causing more damage, and splinting will be covered in the next chapter. We briefly talked about gunshot wounds. We'll talk a little bit more in depth here. Most deaths from our gunshot wounds actually occur due to blood loss. So it's important that anytime we have one of these injuries, we are identifying the blood loss as soon as possible and stopping that blood loss. Any gunshot wound that we have either to the neck or to the main part of the body, the trunk, we always run the risk of spinal cord injuries. As bullets enter the body, they can often bounce around, causing more damage and hitting those nerves, especially the nerves in the spinal cord. Our treatment for these is going to remain the same. We want to stop any external bleeding that we see as early as possible. We're going to maintain our airway, breathing, and circulation. It is important that anytime we have a gunshot wound or we suspect a gunshot wound, that we are examining the patient thoroughly, looking for both an entrance and an exit wound. It's not always that you will have both. It's more common to have an entrance and an exit. But if you only find one hole, that just means that it went in and bounced around and the bullet is still in the body. With these patients, we're still going to treat for shock, just like we would with any of our other patients. Arrange for prompt transport and always be ready to perform CPR if their heart stops from that blood loss. Bites are another type of wound. We can have bites from animals or humans, and they range in severity. All bites have a high risk of infection just because the mouth is so dirty. We also have unvaccinated animals or wild animals that may have rabies. So anytime we have a bite, any minor bite, we want to wash that with soap and water, get it as clean as we can. Any major wound caused by a bite, we want to first control any bleeding, applying a direct pressure bandage over that, and then making sure that they are transported for treatment at a medical facility. In most states, this is one of those required reporting things. So anytime there is an animal bite, they need to be reported to either the local health department or the law enforcement agency. It can also be important, if there was a bite, to be able to identify the animal as well. And if possible, and it's safe to do so, we can capture those animals so that they can be tested just in case they do have rabies or some other type of communicable disease. Next, we will talk about burns. Our skin is our protective barrier that keeps us safe from all foreign substances entering the body. And if our skin becomes damaged due to a burn or some other injury, it loses the ability to protect us from disease. It also loses the ability to regulate our temperature. And these are some of the things that become very prevalent in our burns. There are different depths of burn that we look at. We have our first-degree burns, which is just normally described as our sunburns. This is a red, painful skin. It is only affecting the outermost layer of the skin. These can be mild to moderate pain. Most people have had some type of first-degree burn. Like I said, sunburns are a first-degree burn. As that burn continues and moves deeper into the tissue, we will move on to our partial thickness burns. These are called our second-degree burns. With our second-degree burns, we're going to continue to see that redness expanding. This is when we're going to start seeing blistering. These patients are going to have severe pain associated with that. They will have some fluid loss as the skin loses the ability to keep that fluid in. Normally, though, these will heal fairly quickly, and we'll see within 2 to 3 weeks the skin has healed itself from these, though they do require some treatment and should be seen by a medical provider. Our full thickness burns, these third-degree burns, these are burns that have damaged all the layers of skin all the way down. These are extremely painful because at this point they have damaged nerve endings, and it is also removing that protective barrier to the nerves, so any air movement or anything is touching those exposed nerves. Next, we have our full thickness burns. These are our 3rd degree burns. These ones have damaged all the layers of the skin. At this point, you may start to see that the pain is absent from these because the nerve endings have been destroyed. Though really, if there is a full thickness burn, there's going to be partial thickness burns around it. There's going to be exposed nerve endings. So these patients are still going to have some amount of pain. These patients are susceptible to losing large quantities of blood. They are very susceptible to shock and infection. With our burn patients, the treatment that we're going to be looking for, no, we'll talk treatment anymore. So it's important for us to be able to determine how much of the body surface has been burned as we're giving this report to the hospital or to the incoming EMS personnel. Determining the amount of body surface burned is very difficult, so we use a couple of different formulas trying to figure it out. The most common one that we're going to use is called the rule of nines. And it's important that as we think about the rule of nines, this is only counting the 2nd and 3rd degree burns. If they have any 1st degree burns, that is not calculated into the percent of burn that they have on their body. And so the rule of nines that we use, it breaks the body up into different sections and says this is 9% and this is 9%. So if you look at an adult, we're going to say that our arms are 9%, our chest is 18, our legs are 18, our head is 9%, our back is another 18%. The other there is another way to try and determine the amount of burn that is called the Palmer method, and that is looking at the patient's palm, and based on the size of their palm, you can look at the burn, and each palm is 1%. So if you can't remember each one of the limbs and the 9%, and then it's different for the kids where their head is 12%. So if you can't remember the breakdown of this rule of nines, then we can also remember that Palmer method, looking at the patient's palm equals 1% and then calculating it out from there. But like I said, this is extremely difficult, and if you were to ask 10 different providers to judge the same burn, you're likely to get a different percentage from each of them. It's just good for us to get a general idea and as close of an approximation of the total body surface area that has been burned, as that will go into our fluid resuscitation once our advanced providers have arrived. So we'll talk about some of the causes of burns. So the first one that we'll talk about is our thermal burns. This is direct contact with a heat source. With these, we want to place with these type of burns, we want to treat by putting a dry, sterile dressing over the burn. If there are any blisters that are intact, we don't want to break those blisters. If there is any clothing that is burned or stuck to the body from the burn, we also don't want to pull that off. But we do want to first stop the cause of the burn, so remove them from the heat, dry, sterile dressing. If it is a small percent of burn, then we can consider using cool water to help reduce some of that pain. But the important thing to remember is that with all of our burns, our patients lose their ability to regulate their own body temperature because that skin has been damaged. So if we cool them down too much, then they will begin to shiver and it will cause further problem. So we want to be very careful with using cold or cool water on these burns if it is into our second and third degrees. If it is a first degree burn, we can definitely use that cool water to help cool it down and ease the pain. Another type of burn that we need to be very aware of is our respiratory burns. This is any time there is a burn to any part of the airway. These we want to look for any burning around the face. We want to look for singed nose hair. We want to look for any singed nose hair, if they have difficulty breathing, if they have soot around the nose or mouth, if while they're breathing, it is painful for them to breathe, or if you start to hear any squeaking or raspiness in their voice. This is very dangerous and it can lead to a loss of consciousness. This is very dangerous. It can lead to a loss of consciousness and a completely closed off airway as the tissue in the airway begins to swell, and then they will be unable to breathe. This decline This progression of airway swelling due to a burn develops very rapidly. This swelling caused by airway burns can develop rapidly, or it could develop slowly just based on the severity of the burn. So with these patients, we want to administer oxygen. We want to try and keep them as calm as possible and arrange for prompt transport of these patients, making sure that we have advanced life support intercept coming, or that we get them to the hospital as soon as possible. Next, we will talk about our chemical burns. There are many different substances that can cause chemical burns. The longer a chemical remains in contact with the skin, the more damage it is going to do. So we want to try and figure out what chemical has come in contact with the skin and then begin treatment based on what it is. So we want to remove as much of the chemical as we possibly can. So if we have a dry chemical, we want to keep it dry. And so we just want to brush it away from the skin and get it off that way. If we have a wet chemical, then we can flush it with water then we can flush it with as much water as we can for at least 10 minutes. With both of these and with all of our burns, we want to arrange for prompt transport. We can also have chemical burns in the eye. With all of the chemicals that get into our eyes, we want to immediately begin flushing the eye with water for at least 20 minutes. Sometimes it's very difficult for these patients to keep their eyes open themselves, so we may have to actually hold their eyes open to allow the water to flow over the surface of the eye. Once we have flushed the eyes with water for 20 minutes, then we can loosely cover the eyes with gauze bandages and arrange for transport. We can also have our electrical burns. These occur when we can also have electrical burns. These occur when an electrical current enters the body from one point and travels through and exits at another point. So it doesn't matter if we have come in contact with electricity from a wall or from a power line, or if it is a lightning strike, all of them are the same thing. It's electricity traveling through the body. This electrical current can cause major damage internally and externally. We talked about in one of our other chapters that these patients can often see irregularity. These patients can often see irregular heartbeats or cardiac rhythms leading to cardiac arrest and death. This is one of those times where having our AED quickly on the patient to terminate that lethal rhythm and can make a big impact in saving their life. Anytime we have an electrical injury, we want to make sure that the patient is no longer in contact with whatever that electrical source may be before we treat them, so that we don't become a patient ourselves. If we need to call for assistance from the power company or some other. If we need to call for assistance from the power company so that they can come in and turn off the electricity so that we are able to safely get in and touch our patients. Remember that as that electricity has moved through the body, you may see an entry and an exit wound, but the path that electricity took in the body will also have internal damage and burning internally. So we want to make sure that we calculate that when we're talking about our burn areas and just try and figure out the path that it may have taken as it moved through the body. It's not very often that we have a single wound that isn't affecting anything else in the body. So what we end up with is a multi-system trauma. And this is when more than one of the body systems has been affected. Because of the fact that most of our injuries do actually include multiple body systems, it's important that we are able to look at the patient as a whole, understand which systems have been affected, and how it may progress based on each of those symptoms that have been injured. Now we're going to move into our summary for this chapter. You must take appropriate standard precautions to prevent contact with any patient bodily fluids. So anytime we are treating a wound, make sure that we are protecting ourselves as we come in contact with their blood. Remember that the three parts of the circulatory system are the heart, the arteries and veins, or the pipes, as well as the fluid. And we need to make sure that all three of those are working well together so that our patients don't go into shock. We have three causes of shock, which are either our pump failure, our pipe failure, or fluid loss. Anytime we have a patient that goes into shock, that is inadequate tissue perfusion. So anytime there's not enough blood circulating in the body, whether the heart has stopped circulating it, the pipes have expanded too much, or we don't have enough fluid to carry the oxygen that we need. We have three main types of external blood loss. We have our capillary bleeding, our venous bleeding, and our arterial bleeding. Most external bleeding can be controlled using direct pressure, but remember, never hesitate to use a tourniquet to control that bleeding if you have any question at all. Those tourniquets can be on for 2 hours and more, and most of our transport times are going to be less than that. So if it's severe bleeding and you can't tell whether it's venous bleeding or arterial bleeding, or it's too much for you to control with direct pressure, or you have other things that you need to be doing and you need to free up your hands from holding direct pressure, don't hesitate to use tourniquets. They are safe, they are effective if used properly. Remember that we can have either closed wounds where the skin remains intact, or we can have open wounds where the skin is or we can have open wounds where the skin is disrupted. Or we can have open wounds where the skin has been disrupted. Our open wounds are classified by different types. Remember, we have abrasions, punctures, lacerations, avulsions, and amputations. And then lastly, remember the three types of burns. They're based on the depth of the burn. So our superficial burns, that redness, that is our first degree burns. We have our partial thickness, that is including deeper parts of the tissue. We may start to see blistering on these patients. That is our second degree burns. And then we move into our third degree burns, which are full thickness. Burns can be caused by either heat, chemicals, or electricity. So now we'll move into our review questions for this chapter. First question, which of the following statements regarding standard precautions is true? Standard precautions assume that all body fluids are potentially infectious. Standard precautions assume that some body fluids are potentially infectious. Standard precautions apply to paramedics who perform invasive procedures. EMRs are only required to wear gloves to comply with standard precautions. And the answer on this one is going to be A. Standard precautions assume that all body fluids are potentially infectious. Question 2. Appropriate management of impaled objects in the eye include bandaging only the affected eye, rinsing the eye with saline, bandaging both eyes, removing the object to prevent further damage. And the answer for that one is B, bandaging both eyes. And our last question. Patients with full thickness burns generally do not complain of pain because blister formation protects the burn, nerve endings have been destroyed, deep burns produce a natural painkiller in the patient's system, patient is generally not conscious. And the answer for that one is B. Nerve endings have been destroyed in our full thickness burns. And that is it for this chapter, guys. I know it was a long one. You guys are doing great. I'll see you in the next chapter.